Hi. Menopause is mandatory, suffering is not. I heard this first from Dr. Annika Becca, and I love it because I think it's very true. So, with this presentation, I'm hoping to give you some insights and tools on how to navigate this time of your life, which will be about one third of your life and hopefully longer. You're probably going to hear some things today that contradict what you've heard in mainstream media from your doctor and even from naturopathic and functional medicine doctors. Because of this, I'm hoping that you'll listen with an open mind. The purpose of this webinar is to shine some light and pull back the curtain on so much of the bad press that hormone replacement, aka HRT, has gotten over the past 20 years. When I mention HRT, many women express concern that it will cause cancer. I think that's the number one concern women have, and I like to dispel that along with other concerns. My goal today is to help you better understand the history and research on HRT and how it's ended up with such a bad rap and is so misunderstood. And also to bring information to you for you to have a clear idea of a risk and benefit analysis of hormone replacement, which will enable you to become your own advocate, which I think is really important as you move into and through the menopausal years. It will be interesting to see where you stand at the end of the presentation. So I want nothing more than women of a certain age to be vibrant, full of energy, and feeling beautiful. So with that, let's look at what we'll be covering today. So what we'll be recovering is number one, hormone hierarchy. So we have a hierarchy of hormones, the basics of perimenopause and menopause, the benefits of estrogen and progesterone, each as standalones, the different types of estrogen and progesterone, super important, the history of hormone replacement therapy, looking closely at the WHI study, which kind of set everything up, which is the Women's Health Initiative, looking at the benefits and risks of HRT, what professional organizations are recommending, and then looking at the different forms of hormone replacement. And the fact that HRT is not actually the end all be all is just kind of the icing on the cake. And then I am going to tell you about a course that I am putting together as we speak. It's called Women of a Certain Age and how to opt into that. So I'm going to jump in because it's a lot to cover. So the hierarchy of hormones, this diagram may be a little bit of a surprise to you. I think most of us think that our sex hormones are the most important hormones because when they're out of balance, they can definitely wreak a lot of different havoc and make us feel very, very uncomfortable. But as you can see, they are not the top dog here. So we go from the bottom to the middle to the top here, and you can see that insulin and adrenal hormones are really number one. And then thyroid hormones come in second, and then our sex hormones come in third. And again, the thyroid and insulin and cortisol, adrenal hormones, are essential for life, and sex hormones are not essential for our life. Again, you can feel pretty crappy, but we can live without them. So let's talk about what the other hormones do, just real briefly, okay? So again, insulin is the top dog of all of these hormones. It regulates our glucose. It reduces inflammation, or it can increase inflammation if it's high. And it's actually our fat-storing hormone. So I hope you hear that. It's your fat-storing hormone. So if you are running around with high levels of insulin, then it's going to be really difficult for you to lose weight because your body will want to be storing fat. And how do you know if you have too much insulin? You do it with measure it with a simple blood test, which most doctors do not do, unfortunately. Okay. And then we have cortisol, and it's also super important as it has a huge effect on our sex hormones, and it can also contribute to inflammation and excess stress as well. And stress obviously causes more cortisol. So we make all of our sex hormones also in our adrenal glands. So if we require a lot of cortisol, then that's all going to be shunted over into making that cortisol. And when we're going through perimenopause in particular, that can make that whole time period a lot more uncomfortable. It also can have an influence on incontinence and hot flashes. Okay, that's definitely part of our hormones dropping, but a surge of cortisol or adrenaline can compound the factors or the problems with hot flashes and blood pressure as well. And then thyroid obviously is important. It runs our metabolism of each and every cell, which means our overall metabolism. And if our thyroid hormones are not adequate and there's a lot of symptoms, we can feel like we're experiencing perimenopause at a heightened level. And so it's exacerbated. So, since these three hormones are so important, it is essential to have good and thorough screening of them, which again, most allopathic doctors will not do. And I actually do have a companion guide where I talk about that. It's called the Companion Guide to Essential Blood Work. And I will be attaching that to the email that you'll receive after as a follow up email to the presentation. So again, most doctors don't adequately test for these, and it does influence how you move through menopause and how you feel in general. So we're going to talk about perimenopause first before we go into menopause. And perimenopause is what happens on your way through or to menopause, and it's often caused or called your second puberty. And that's because um, our bodies are going through this big, huge change. And it's similar to a change that it was going through during puberty. I mean, it might take 1 or 2 years before young women can actually find a rhythm with their cycles because their body's kind of going through everything. And just the opposite is happening when we go through perimenopause. So you can feel like you're on a roller coaster during this time. And of course, it is for a reason. Your ovaries are starting to shut down and they are scrambling to write things again and to find that rhythm. Let's see. And again, some women have very little or no symptoms as they move through perimenopause into menopause. Lucky them. But I would say that most do, and it's not a very nice ride. So let's look at what is first happening when we kind of start to move into perimenopause. First of all, it happens 2 to 12 years prior to menopause, which occurs on average at the age of about 50. And this period, we can experience heavy periods and mood swings, insomnia, and night sweats, and just brain fog, all of that. And what's happening is our progesterone usually drops first, which is why anxiety and insomnia can kind of come in there. Progesterone is very, very calming. It's a very, very calming hormone. And when that starts to drop, we can start to feel all sorts of things where we want to bite someone's head off. Okay. We're anxious, we don't feel very good in our own skin. And then this drop in progesterone is then followed by the drop in estrogen. And again, the health of our adrenals can play a role in this transition because we make all four of our sex hormones in the adrenal glands. Okay, so once we have moved through that period of perimenopause, we have now crossed the finish line and we are in menopause. And what this artificial line is, or marking of time, is when we haven't had a period for a year. It's kind of a made up time, but it is what it is. And this is how many women experience menopause. They experience menopause as being feeling frazzled and frumpy and fat, but it doesn't have to be that way. You do now have next to nothing in the way of estrogen and progesterone, and your testosterone has dropped as well. And your body no longer has the protection it had from estrogen for almost all of your life. And it no longer has the same calming abilities it had received from progesterone. So it's kind of a bad party trick that we've been made this way. Or, we can experience menopause as the previous slide, or it can be a graceful, wonderful, elegant time. It depends on whether or not you have the right tools to gracefully slide into that. So it's true that menopause is going to affect every tissue and organ in your body, every tissue and organ. And you have the option to be friends with your body during this time or to fight it. And I don't know about you, but I'd rather befriend it as it's here to stay again for many years, which means it's best if you can understand it better. Our 60s and olders are a time where we can bring a lot to the world. We've lived a lot, we have experience and wisdom, but if we're feeling old and frumpy and brain foggy, it's pretty hard to put all that to good use. But if our bodies are getting the support they need, we can continue to thrive and be forces in this world or whatever else you want to be. So let's look at the benefits of estrogen, and there are many. So the benefits includes, and I'm going to try to read this, um, increases your energy and focus. It does improve sleep. It prevents osteoporosis. That's been proven again and again. It's neuroprotective, so it can help prevent dementia and Alzheimer's, although a new study just came out to debunk that. But you have to be able to understand how to read these studies, which you're going to learn how to do in a big way before this presentation is over. It keeps urinary tract healthy, so UTIs stay away. It reduces incontinence. It regulates weight. It regulates appetite. Yeah. It modulates moods, increases sensitivity, glucose and insulin sensitivity, so it helps to prevent diabetes. And then it keeps inflammation in check. Estrogen does, the right kind. It affects and it supports our digestive function and prevents gallbladder issues and reduces breast and ovarian cancer. Yeah, you just read that. Okay, we'll touch on that again. So there are three different types of estrogens that our bodies make. So an estrogen is not just an estrogen, just like a carbohydrate is not just a carbohydrate. We can find carbohydrates in highly processed white grains, or we can find them in whole grains, which are better types of carbohydrates, right? Or we can find carbohydrates in vegetables and fruits. So they are not all equal in what they can bring for us and how much they cause inflammation. Same thing with estrogen. So it's really important to understand these three different types and to know the distinctions between them, especially when anyone is referring to a study. You need to know what type of estrogen and progesterone, for that matter, was being used and the delivery system. So this is really, really important. Okay. Um, So let's look at the types of estrogen, then I'll go back to the delivery system in just a second here. So estradiol, which is called E2, is the most abundant form of estrogen that we have in our bodies and that our body makes. It's made in the ovaries, and it is actually anti-inflammatory. Okay. Now, from estradiol, our bodies can make estrone and estriol from that. So estrone, which is called E1, excuse me, this is the type of estrogen that can cause more inflammation. And we do need some inflammation to survive. Okay. So we have to have some or we would bleed out. We have to have some, and our body would be able to fight infection. And again, it can be converted from estradiol. And it's also produced by our fat cells. And I'll talk about that in just a second and how we relate belly fat with menopause with producing estrogen. The third type of estrogen is estriol. Again, that's made from estradiol, and it's most abundant during pregnancy. It's also very anti-inflammatory, and they're actually doing some studies on how it can help um, highly inflammatory and maybe even autoimmune diseases like MS. So just calming everything down, and that makes sense when you're pregnant. You don't want the immune system to attack the fetus, right? So I think that's the body's mechanism for making that type of estrogen just to calm everything down. Okay, so delivery system, I'm going to talk about just for a second here, and I might allude to that again. But especially in HRT, okay, either we can have it, I'm not going to go into it here. We're going to go into it in another slide. Okay, so let's talk about the menopausal bulge. So you heard me talk about estrone, which is E1, and it is made from estradiol, but it's also made from our fat cells. So during perimenopause and menopause, when our estrogen levels are tanking, right, our body is really doing everything that it can to keep those levels up. And estrone is produced in our body from fat cells in both men and women, actually. And so there's a tendency for women to put that abdominal fat, a little bit of back fat around that middle. And that is in response to our bodies are just trying to make a little bit of more estrogen in the form of estrone. Now, remember that that's inflammatory, right? So we don't want to have a whole bunch being made by the belly fat. We don't want a whole lot of belly fat. And if we're getting a little bit of HRT, hormone replacement therapy, that will help prevent that whole thing from happening. Okay, is there anything else I want to say about that? I think that's it. Okay, so we're going to move on to progesterone. Benefits of progesterone, they're huge. And it's often forgotten, and especially if a woman does not have a uterus, because technically you don't have to give progesterone to prevent the growth of the uterine lining if you're giving a woman estrogen replacement therapy. Okay, so if you don't have a uterus, it's not going to grow, right? It's not going to grow the lining. So a lot of doctors won't give progesterone, but if you look at all of the benefits that progesterone gives you, it's much more than just preventing the growth of the uterine lining. And you can supplement progesterone without estrogen. You can, but I don't recommend it the other way around. So the benefits of progesterone: prevents the thickening of the uterine lining, which I already mentioned. It's very calming. It improves sleeps. It prevents osteoporosis. Okay, so does estrogen. But if for some reason you feel like you can't take estrogen, then progesterone would be the way to go. It lessens anxiety. It builds muscle, which I don't think a lot of people realize. I think we always think of muscle building associated with testosterone. And then it's also neuroprotective in Alzheimer's and dementia. So let's look at the different types of progesterone. And this is super, super important and key. I want you to notice how different both of these types act in our bodies. So we have progesterone over on the left-hand side. So this is what our body makes. This type of progesterone is also available in a transdermal and an oral form, and it's fine either way. And this is what another form of progesterone does. Progestins, okay, is extremely different. Let's look at the differences here. I can't read my slide. Okay, it improves cardiovascular health, may reduce the risk of breast cancer, and is good for mood and sleep. So all the things I already mentioned in the previous slide. But progestins can cause high blood pressure. It can also increase the risk of breast cancer, and it can also increase anxiety and depression. And key, I don't know why it's not down there, it also can increase the risk of cardiovascular disease and stroke. Now, where do we find these progestins? Okay, if progesterone is available to us in hormone replacement therapy, why the heck would we use progesterones at any time? Well, you'll find out that that was a type of progesterone that was used in the Women's Health Initiative. And progestins are the type of progesterone that we find in birth control pills. And there is that warning for birth control pills that it can cause depression, it can cause mood changes, it can increase the risk of stroke and cardiovascular disease. So kind of keep that in mind when you're putting maybe your teenage daughter on birth control pills. Is it to regulate their periods, or is it to prevent pregnancy? And if it's to prevent pregnancy, you might want to go a little bit different route, and you need to know all of the factors around it. So progestins, we know there's a risk factor there. Okay, we are moving on to the history of hormone replacement. So in the 1940s, Premarin, which was an equine, an estrogen that was taken from the dried urine of horses. Okay, that's how they were developing it. And it was they were using estrogen only. It was FDA approved. It was oral, and it was used to treat menopausal symptoms like hot flashes and mood swings. And everyone was kind of happy. And then in 1966, the book Feminine Forever had women flocking to the doctors for HRT. That was just kind of when it exploded. And then in the 1970s, it was like a kind of an uh-oh moment. It's like, oh, we need to give progesterone and to make sure that there is no increased risk of uterine cancer from the uterine lining thickening through just the use of estrogen only. And this was given in the form of progestins, right? Okay. In 1992, HRT was the number one prescription in the US with over 1 million women using it. That's a lot, okay? In 1993, that's when the Women's Health Initiative study was started. So the WHI study was started, and that lasted to 2004. It was the largest randomized clinical trial at the time and actually since. And the authors were actually contracted, or the study was put together to track the cardioprotectiveness of estrogen. That's really why it was put together. There was about 27,000 in the study. About 16,000 had a uterus, and about 10,000 without a uterus. There was 3 arms of the study. The one arm was just estrogen only, and again, that's the equine estrogen, which is not something our body makes at all. Okay, and it was oral. And then there was estrogen and progestin, and then a placebo. So going back to the estrogen, again, the type they were using was the equine, and that was basically a form of estrone. So inflammatory, right? Okay. Just want you to follow along with me here. And then in 2002, one arm of the WHI study was stopped, as there were some indications that there was a very small increase of breast cancer, heart disease, stroke, and blood clots. Although later evaluations of these results have since refuted that, and the results have been conflated with the type of hormones used, in particular progestin. So again, so the arm that was stopped was the arm that was using estrogen and progestin, and it caused, when they stopped the arm, what they did is they released the report to the press, to the media, without it being peer reviewed. And it caused a total panic amongst women, of course, who were using hormone replacement therapy. And of course, it caused a panic with doctors as well. So all of a sudden, we have all of these women coming off of their hormones. Probably not a very fun place to be. Okay, in 2004, the remaining arms of the WHI study clinical trials did stop, and the findings were really starting to be scrutinized. In 2017, we're kind of jumping here. NAMS, which is the National National American Menopause Society, recommends using the smallest dose possible for the shortest period of time possible, mainly to relieve vasal symptoms, so hot flashes, things like that, and menopause. So that's what came out, and I would say a lot of practitioners, that is what they follow, that kind of mindset. And then in 2020, it was reported that women using estrogen-only HRT had a reduced risk of breast cancer incident. So in other words, they're looking at the study a little bit more, and mortality. And combined HRT had a slight increase, but did not translate into an increased risk of mortality. So I just want to make sure I don't miss something here. Okay. So the basic flaws of the WHI study. So I don't know how many of you know of Dr. Sarah Gottfried. She's great. She's written like 3 or 4 books. I recommend her books to her. I trust her. She does her research. So to quote her, she says that this study was the wrong study at the wrong time with the wrong people. So what is she talking about here? Well, the wrong people, okay, is the average age of the women who were in the study. The mean age was 63. And that means that most of these women were 13 years past the onset of menopause, which means that's 13 years for a lot of time for inflammation and some cancers to start to develop, some other things to develop. And these women were not screened to make sure that none of that was going on in the background prior to coming on to the study. So again, plenty of time for inflammation to have set in, and they weren't screened for any existing cancer, blood clots. Many of them were obese and some were smokers. And dosing perhaps not age appropriate. There are some that say that it wasn't high enough. And then also some have criticized that the progestin was a static dose, that it wasn't like a 2-week on, 2-week off, or 3-week on, 1-week off, which a lot of practitioners now think that that is necessary to do to give the body a break. So the method of delivery was oral. And what that means is that when we take or estrogen orally, it has to go through the liver. It has to be conjugated, which means it goes to liver, and then it's conjugated with bile. The bile takes it to the small intestine, and then the bile moves through the small intestine, and then it's excreted out with your stools, basically. Okay. So there's a lot that can happen. It might not be conjugated correctly. There could be what we call issues or leaky gut or other things going on in the gut where it actually deconjugates. What that means is it breaks the waste estrogen that's in the gut waiting to be excreted out. It'll break it apart from the bile and it'll be reabsorbed. So there's always a problem. I don't care what type of estrogen you're taking orally, whether or not it's estradiol, which is the kind that we want, or it's estrone, which is the inflammatory type, which is the type they used in the WHI study. Either way, you have the chance of it being broken apart and reabsorbed here. Okay. And it's converted into its more inflammatory form, estrone, whenever we go through orally. Okay, that's the method of delivery. And then the type of estrogen and progesterone were used were not bioidentical. I've already hit on it. The study used oral conjugated versus dried urine. It's called CEE. And that was mainly estrone. And then the arm that was also taking the progesterone, the progestin was used, and neither one of these are naturally made in our bodies. So, and I already talked about the dosing. All right. So I am going to talk to you a little bit about what the National American Menopause Society, or NAMS, what their position is, their 2022 position is on HRT. And it's interesting. And this is a society that has a lot of clout, not only in the US, but internationally as well. And this is an update from the 2017 statement, which is 5 years prior. And it's used by many, but not all doctors for formulating their guides and how they choose to dispense their HRT in their practices. I think a lot of doctors, unless they've really been educated, um, are still using kind of the 2017, which is a little bit outdated, that mindset, those recommendations. And so I'm taking this from a report, again, that came out in 2022. And if you're curious to the link to this 28-page report, I will include that again in the email that you'll be sent, which will have an attachment to Essential Blood Work Guide. I found it extremely interesting. So NAMS basically based their statement on, many different reports that are out there, but they also acknowledged that their findings and this report was heavily reliant on the Women's Health Initiative study. And they acknowledged that there's many flaws with this trial. But, they've got that, and then they have considered other studies or meta-analysis of various studies that are out there. They did acknowledge the limitations of the WHI in terms of types of hormones that were used and the age of the women included in the study. And of course, they did include references when making a statement or a conclusion. And I found it really interesting to follow the breadcrumbs to see the references to making the conclusions. And I may refer to that. So I am going to start with cancer because it seems to be, again, the biggest concern for most women. And the first thing that you see here, and that's in their statement, is that HRT does not cause cancer. Okay. It's still out, the jury's still out in some camps on whether or not it can make it proliferate, but it does not cause it. And it does not increase deaths due to cancer either. So I'm going to actually read from their report, their statement here. So reevaluation of the WHI study, okay? So they're saying 20 years of median cumulative follow-up. So they've done 20 years of follow-up, okay, after the WHI. And what they said in the report was estrogen only, and this is the estrone equine urine, okay, alone was associated with significantly lower estrogen only therapy, not in the best way, it's orally, not the best kind of estrogen, has been associated with lowering breast cancer incidence and breast cancer mortality compared with placebo. Okay? In contrast, the estrogen and progestin was associated with higher breast cancer incidence. So the two of those, right? We got that progestin back in there, but no significant difference in breast cancer mortality compared with placebo. Okay? I'm reading it. The mortality risk of breast cancer in hormone therapy users has been reported to be reduced in many, but not all, observational studies. Less than one additional case per 1,000 women per year of hormone therapy has been seen. They also say that women should be counseled about the risk of breast cancer with hormone therapy, putting the data into perspective with risk similar to that of modifiable risk factors. A lot of words. Such as 2 daily alcoholic beverages, obesity, and low physical activity. In other words, HRT has less causal effect on breast cancer than drinking 2 alcohol drinks a day, being overweight, and not being active. Okay. So it you have to put in perspective, and I think they did really a nice job. Okay. So is there anything else I want to say about the cancer? I think that's it. Okay. So in their statement, they did state hands down that it's HRT is effective in prevention of osteoporosis, and actually it has been FDA approved for that. Cardiovascular disease, the jury is still a little bit out on that one. Diabetes, they're a little bit conservative. They say probably can help. We already know that estrogen affects every single tissue in our body. Okay. Urogenital, it's very effective in preventing prolapse uteruses and UTIs and things like that. So often when a woman hits menopause, the amount of UTIs she has just becomes unbearable. And interstitial cystitis as well. And I've treated all of those in my practice. Okay, so what I've done here is I've kind of put a risk benefit analysis, and I am realizing that I cannot even see that. But what I've done is I've put the condition and then the normal treatment for it, and then the risk for either the actual treatment or not treating it. Okay, so UTIs, I'm not going to go through all of it, but I'm just going to hit on UTIs. All right, so if we have repeated UTIs, we're going to have a repeated rounds of antibiotics, and that is going to change your whole gut flora. It's going to change your whole digestive system, and you're going to have problems there. I'm going to hit on, bone loss, osteoporosis, obviously. The medications they have to try to keep the minerals in the bones, you have to always take them or it will your bones will start losing it. Same thing with HRT, actually, with osteoporosis. Once you stop it, the bones will start to demineralize, unfortunately. But if we don't take care of our bones, if you break a hip, um, life expectancy does go down, and if you start breaking some bones here, then your ability to stay active is also compromised. So it's kind of a domino effect here. Alzheimer's and dementia. Again, there was a recent report that came out that HRT actually contributed to it, but we had to look at the type of hormones that were used. And again, progestin was used. And it was oral for most people as well. So not a really good study. And you have to go past the statements and the conclusions and look at least far enough to look at what is it? What forms did they use? Okay, because we don't have to use those forms anymore. All right, so depression, anxiety, and substance abuse. I'm going to kind of put that all into one because when we lose progesterone, we tend to have more anxiety, but that can be with serotonin as well. And progesterone hits on more of the GABA neurotransmitters. Estrogen has more of an influence on the serotonin. Either one, GABA or serotonin, can, when they drop, and if it's kind of driven by the hormones here, we can see women who used to drink socially all of a sudden have a drinking problem. In other words, there's alcoholic abuse, unfortunately, alcohol abuse. So that's not something you ever want, right? Okay, diabetes, yeah, we can go to metformin, or maybe we can make ourselves a little bit more sensitive, insulin sensitive by getting rid of that belly fat, and by estrogen just helps to promote our cell sensitivity to insulin. Constipation. So that's one, I'll be honest with you, that I found an increase of when I hit menopause. And for some of us, just genetically, I have a genetics SNP where I have a hard time making bile, and bile does so many different things. I have a great post on my website. But one of the things that bile does is it helps to break down and absorb fat. That's one thing it does. It also helps with gut motility. It pushes things through. And if you don't have the raw materials to make the bile, an estrogen can affect that ability to make it. Then you can have a lot more constipation and just a lot more issues with digestion. Estrogen also is protective, the right kind of estrogen, of the gut lining so that we don't end up with a leaky gut and again have compromised digestion. It's really difficult for us to eat certain foods. Okay, so I think you kind of get the picture. I have one more here. And, high cholesterol, usually when our estrogen kind of drops, our cholesterol can go up. It's not necessarily a bad thing. And, your doctor might want have you go on statins. And with that, we're going to have a loss of muscle often. And we can often also have a lot of muscle aches and pains, things like that. Let's see, what else? I can't read the other one here. But the object of what I've done here is, okay, I think all of us are susceptible to these conditions. And we know that either personally or we know that just by watching our contemporaries. So if this is going to happen, and this is the way Western medicine is going to treat it mainly, okay? And this is possibly the outcome. And I just, read you the report from NAMS, right? Menopausal Society, saying that we don't have a lot of the risks that many women and even doctors are concerned about. Why wouldn't we? For most women, not everybody, of course, right? But for a lot of women, I would think that HRT, the risk benefit here, there's going to be more benefit than risk. Okay. So that's the purpose of putting that out there. I am going to touch real briefly on the different types and methods of HRT. I've already alluded to some of them. So this is what's available today. We have oral. So we can have oral progesterone, oral progestins, or oral estradiol, which is what kind we like, or oral estrone. Premarin and Prempro. Premarin is just the estrogen only. Okay, so that's the equine estrogen, and Prempro, which is the equine plus the progestin, which is what they use in the WHI study. Those are still available today, and there are some doctors that still prescribe it. Why they do that, I have no idea. When we have so many better options, I just don't get it. Okay, if anyone tries to, I am going to recommend that you run. Okay, so transdermal is my favorite because it doesn't have to go through the digestive system. It doesn't have to go through the liver. We can have a transdermal in a form of a patch or cream or gel. And I would say that's the most popular form of hormone replacement that doctors use. I'm not going to hit on pellets. Let me go to vaginal. So this would be the most conservative, and there are a lot of doctors, and even in the NAM study, they made mention that the vaginal they feel is pretty safe, even with a woman that has a hormone-driven breast cancer, because it's not systemically absorbed by the body. It is a little bit, but it can be a lifesaver as far as treating vaginal atrophy and UTIs, preventing the UTIs, and be able to have sex comfortably. Okay. And that's important. I mean, that's part of quality of life, in my opinion. Okay, pellets. I know some women love pellets. There are many doctors who love pellets. The problem with pellets is you're given an injection, and if it's too high, too low, whatever, you're stuck. So that's one problem, okay? You're stuck. And I've had some clients that has been a nightmare for. They were given testosterone, progesterone, and estrogen. And they felt horrible for at least a month. So you get the injection, it lasts for about 4 months or so. So it's really potent in the beginning. So you get kind of like a steroid high, this hormone high, which can feel really, really good for a lot of people in the beginning. And then it wanes over that 4 month period. And you're kind of like, oh, what do I get my next injection here? And since it's such a roller coaster, it can play havoc on the body. And I have heard that many women, after using it for 2 or 3 years, will actually need to have a hysterectomy because it just hasn't worked well. And the other caution with that, and it's not just with doctors that give pellets, but it tends to be more with the doctors who give pellets, is like they've gone through a weekend course on how to do it, but they haven't really been educated on all the other important components to being healthy as we grow older. So they call themselves anti-aging clinics, but really all they're looking at is anti-aging you with hormones, and that is not the end all be all. And they make money on this. They do. Okay. What else do I want to say? As far as progesterone is concerned, you can take it orally or you can do it transdermally. And either way is fine. Some people do better transdermally, some people do better orally. Um, I have heard that transdermally that it's not absorbed as well as the oral. But either one is fine. And there is a prescription form of prometrium, which is the oral, and that's perfectly fine. Okay, when to start and stop HRT? Wow. You can start somewhere in your perimenopause years. It depends on you, depends on your practitioner. I would say if you're going to start it and you're still menstruating, that you probably would want to have a month-long mapping. In other words, kind of see where your hormones are throughout the month so you can kind of get a better idea of where to pulse. If nothing else, you just might possibly want to start taking progesterone. If you're really having a difficult time with anxiety and sleep, that can be really helpful. There are herbs that you can take during perimenopause, which I kind of like to start there. And then go from there. I just thought of something. Okay. And you can start later. You can start when you hit menopause, or even 10 years afterwards. And, true, studies have shown that the effectiveness of using hormones is not as good um, as if you started earlier, right when you went into menopause. It's not as effective, but it's kind of like a savings account, right? Or a retirement account. It's best if you start contributing to it in your 30s. And then maybe if you don't in 30s, then your 40s and your 50s. And if you haven't by then, well, okay. But it's better to start whenever you do start. Okay. You're still going to get benefit from that. Now, your receptors may have gone pretty quiet and it might take a little bit to get them going again. You might be a little bit uncomfortable at first. You can have that. But I would say you can start it at any time. Duration, forever, as far as I'm concerned, as far as what I've been reading, with proper testing and monitoring. What I mean by that, yeah, you do want to have your hormone levels tested periodically, and perhaps in the first couple of years, or first year or so, when you're trying to find that balance, maybe have an ultrasound to make sure that your uterine lining is not becoming thickened, and periodically, and you may want mammograms as well, just to make sure there's nothing going on there. I'm going to back up here for just a second. And I want to put this in perspective. I don't want to miss this. The WHI study, basically stopped in 2020, basically stopped the use of HRT, right? And so what that also means is in medical school, the teaching of HRT basically stopped as well. Okay. So I know many of my clients, and me too, we get frustrated at, how doctors are so hesitant or don't know very much at all about HRT. And they don't. They don't. It's not really talked about. It hasn't been taught basically in the last 15, 20 years. I mean, they really have to go out on their own in order to try to get some type of education in this arena. And some of these organizations like NAMS, right? They've changed their position from the littlest amount to, well, they've changed a little bit, to maybe 10 years out. Okay. You can pretty much get hormone replacement. You can get it online now. Okay. You can go to an online like Winona. You can do that online. If you are between the ages of like 48, I think, up to about 60, they will just have you do a questionnaire, pair you with a doctor, and you will be able to get your hormones. All right. Um, but we run up against a lot of people that don't know too much, a lot of doctors that don't know too much. So that's the only thing I wanted to have you track with me. And it's been difficult to go beyond, let's say, what the NAMS reports have said. And doctors, need to kind of toe the line if they want to stay in good standing with the AMA and also with their insurance company. So that's what they've been up against as well. All right. So again, HRT is not the end all be all, ladies. It's not. We have to look at all these other factors. HRT is that icing on the cake. We need to look at nutrition. We need to look at lifestyle, sleep, stress, body movement. We need to look at gut health, make sure it's working well and correctly. We need to look at our environment. We need to look at environmental toxins. And we also need to look at our adrenal and thyroid health and uh, blood sugar, our metabolism, or our metabolic health. That's what I want to say. And we can see that through better testing. So all of these are part of um, making sure that we are getting adequate care. So before I go there, I just want to go back here for just 1 second. In order to address all these, it takes a lot of education. It's hard to do that on our own, and it's hard to make changes on our own, which is why I am putting together my course, Women of a Certain Age, which I'm really excited about. And it is a course that will have 8 modules, and it's a course that will be available for you to purchase where you can do it on your own. There's many videos with it, guides. It's a very, very comprehensive, complete program. So that's kind of a self-guided portion of it. And then you're going to have an option to also purchase that along with meeting once a week with me and about 14 other people. So that you'll be in a community, which I think really helps us again make changes as we feel supported. We can ask questions. We can share wins. We can share some places that are tough for each other, and we all have different things to offer to each other. So my dream is to have more of these types of programs where there are communities and we're walking through it together. And I'm hoping to have this course up by August or September. I'm still in the process of it. And anyone who has signed up for this presentation will be given first option to sign up for the community group course, which again will be maximum 15 people through each group. It might only be 12. Since this will be a kind of a beta for this particular program, there will be a discount. And then after that, the price will go up. We'll just be more seasoned. What else do I want to say about that? I think that's it. I probably will be running 2 of the group programs at once. So you have a chance to opt into 1 or 2, and it will all be virtual. Okay, so we're almost there. So things to remember. I want you to remember that it's important to understand the studies and the analysis of the studies. Most importantly, it's you have to know what type of hormones they were using in the study and the method of delivery. That says it all right there. Okay. Understand again the different types of estrogens. I've already talked about that. And knowing that HRT is not the end all be all, and we have to incorporate other things. And it's super important to find a practitioner who listens and supports you. And no one size fits all. You might have to play with this, hormone replacement for a little while if you choose to do it. And, you know, be with a doctor who will listen to you and keep learning and become your own health advocate or find someone who can help you become that. Okay. Some resources for you. I'm just going to put out some names here. Dr. Laura, Lara, Bryden, Dr. Sarah Gottfried, Dr. Felice Gersh. You're going to find her on YouTube. She's also got a book. In general, Dr. Mark Hyman, his podcast, The Doctor's Pharmacy with an F, is awesome. I don't necessarily agree with him on his stance. What I understand his stance is on hormones. He interviewed someone that's out of his clinic, and they kind of subscribe to the 10 years and less is better. So I don't necessarily agree with that. So I hope that was helpful. Please look for a follow-up email with a link to the NAMS PDF and also to the PDF, the guide on essential blood work. Thank you so much for watching. I hope it was helpful. Take care.